I've been asked to speak about the role of transplantation, both in the past and where it's going to go in the future. So transplantation has been a popular modality for patients with multiple myeloma since the late 1980s. So this is not a new technology. This is not a new idea. Transplant has been important because it was one of the first things to be shown to have the ability to overcome resistance in patients who had been treated with other modalities, and that's what established the role of transplantation. What happened after that is that transplant got moved further and further up front and became a standard part of the therapy for newly diagnosed patients, and has remained popular for now a generation or two. And has there been something that has come along that it will supplant it? Well, I mean, today we have a lot of interesting modalities. We have 10, 15 drugs that are effective in multiple myeloma. We have new technologies that are coming along, like CAR T cells and antibody drug conjugates and bispecific antibodies, other immunological therapies that are very exciting. So does transplant remain important? Well, transplant continues to have a number of advantages. It is relatively inexpensive, relatively not toxic in terms of its long-term impact on patients. But the real question is going to be, what does a myeloma patient look like after a stem cell transplant, as opposed to some of these other modalities? And that's a very, very complicated question today, partly because we don't really know what are the best endpoints to look at, and partly because we have such long timelines now that it makes acquiring the data very, very difficult. So we've started to talk about minimal residual disease as a legitimate endpoint. And transplant continues to achieve very, very high levels of minimal residual disease, so it remains competitive from that perspective. But I think that one of the things we're going to see over the next few years is the ability to identify patients who are going to do very badly. There's enormous databases out there now. One of the more interesting ones is called the COMPASS database, sponsored by the MMRF, 1,000+ patients who are being followed really quite meticulously with whole genome sequencing and molecular characterizations, a very comprehensive analysis of the patients. And they're beginning to identify subsets of patients that we know are unfortunately going to do badly despite the most aggressive, most modern kinds of interventions. And we start to understand that as we treat patients, the percentage of patients who look like that starts to go up. So we're going to start to judge our therapies based on which interventions are the least likely to cause the acquisition of that look, that very dangerous subset of changes in the cancer cell that and not just the cancer cell itself, but in the environment of the cancer as well, that predicts for very bad outcomes. So I think that the most important denominator isn't going to be the number of patients and their progression-free survival, but their progression-free survival combined with the knowledge of our impact on the evolution towards that poor prognostic look of the disease. As far as I'm concerned, transplant is here right now. I think that transplant does some very interesting things. There are patients who get a stem cell transplant and then we watch them and they stay in a remission for 20 years. There's a significant number, perhaps more than 20% of patients who go through a stem cell transplant without any further supportive care who stay in remission for a decade. And are there other things that we do that do that? not as far as we know right now. So I think that transplant remains important. We're going to see the therapies judged by a whole different set of standards as we start to understand the biology of myeloma better.